Hi, I'm at the ASH meeting and I will be presenting data, a really exciting data, on the role for PET-CT in managing patients with CLL. Patients with CLL can transform to either diffuse large B-cell lymphoma or Hodgkin lymphoma. When that occurs, we call it a Richter's transformation. This is named in honor of the pathologist Maurice Richter, and that particular event is associated with a poor prognosis for patients with CLL. They have a survival ranging between 3.1 and 3.5 months. There have been data that have been previously reported using PET-CT, which can help to distinguish CLL from Richter's transformation. And these are data that were largely generated in the era where patients receiving chemotherapy or chemoimmunotherapy. And the test characteristics for that PET-CT would be ranging between 91% sensitivity, 95% specificity, excellent test characteristics. There are very little data for how to use a PET-CT to distinguish CLL from Richter's transformation following kinase inhibitor-based therapy. A recent study has been reported using venetoclax in patients who have failed either ibrutinib or idelalisib. As part of that study, all patients had to have a PET-CT as part of screening to help rule out Richter's transformation. If they had a very bright PET-CT, meaning an SUV max greater than or equal to 10, or they had an SUV between 4 and 10 with some high-risk features, they were required to have a PET-CT, required to have a biopsy to confirm Richter's transformation. So this is an excellent opportunity to confirm those characteristics of PET-CT in this particular patient population. So we identified 167 patients, all of whom had a PET-CT, and then we looked at 35 patients who went on to have a biopsy because they had some high-risk feature that was associated with a high suspicion for Richter's transformation. Of those 35 patients, only 8 had Richter's transformation, 2 had another malignancy, and the other 25 had CLL progression, which was a little bit of a surprise. So we went on to calculate the test characteristics of the PET-CT using that cut point of 10 or less to help define a patient who was at high risk for having Richter's transformation, and that we found the sensitivity and specificity were markedly different from those that had been reported from the chemoimmunotherapy studies, suggesting that you couldn't really use the PET alone to help distinguish CLL from Richter's transformation. So of those 167 patients, 125 went on to be treated with venetoclax-based therapy, and then we wanted to start to ask other questions, like what's the incidence of Richter's transformation in this particular population after all of those patients had been already excluded from participating in the venetoclax study. And we found that an additional 6 patients went on to have Richter's transformation. We described the clinical characteristics and genetic characteristics of those patients, and then we went on to take one more step. There have also been data reported from chemoimmunotherapy studies suggesting that in CLL progression, using a PET-CT with a cut point of greater than or equal to 10 could define poor outcomes. Those who had a brighter scan had an inferior outcome. We asked the question, is that also the case for venetoclax-based therapy? What we found, while there was no difference in response rate, no difference in MRD, we did find that there was a significantly inferior progression-free survival for the small subset of patients with CLL progression following a kinase inhibitor who had a PET-CT that was greater than or equal to 10. So this is a potential radiographic marker for poor outcomes with venetoclax-based therapy, or more importantly, to identify that this is a marker for patients who will do well, as the majority of patients had a PET-CT with an SUV max of less than or equal to 10. So in conclusion, the PET-CT is probably not the best test for distinguishing Richter's from CLL. For some reason, and I don't have that explanation, I wish I did, the PET seems to be more metabolically active following kinase inhibitor-based therapy, and that finally, when you're treating a patient with venetoclax, if you happen to have a PET beforehand, those patients who have an SUV max of greater than or equal to 10, who don't necessarily have Richter's transformation, still have inferior outcomes. And I think that's a great patient population and a great marker to identify patients for venetoclax combination studies.